Dear students, this video is regarding the indirectly acting cholinergic drugs, otherwise we call it as anticholinesterases. Okay, so what are anticholinesterases? These are the drugs which provoke a response through the muscarinic or nicotinic receptors by inhibiting the cholinesterase enzyme. So they act by inhibiting the cholinesterase enzyme, or we call it as acetylcholinesterase. Okay, so we have the reversible and irreversible drugs. That is, the reversible is carbamates, physostigmine, neostigmine, pyridostigmine, rivastigmine. Non-carbamates, we have edrophonium, tacarine, galantamine, donepezil, and irreversible ones are there. Yes, organophosphates, difluos, ecothiophate. Carbamates, we have carbaryl and propoxyl. Nerve gas poisons are the sarin, soman, tabun, diazinon. So these are the indirectly acting cholinergic drugs or anticholinesterases. So these drugs, they are esters of carbamates, okay, that is the carbamic acid or the phosphoric acid. So we all know that acetylcholine, how it get hydrolyzed, isn't it? Yes. So this acetylcholine is get hydrolyzed by the acetylcholinesterase enzyme. Yes. So what they do, they specifically cleaves the acetylcholine and it, to form acetate and choline, and thus terminates its action. So inhibitors of acetylcholinesterase, okay, or we call it as cholinesterase inhibitors, indirectly provide the cholinergic action. How? It prevents the degradation of acetylcholine in the body. So as a result of that, acetylcholine level in the body will increase. So that results in the accumulation of acetylcholine in the synaptic space, and there will be an increased intracellular response in our body. So that's how the anticholinesterases act. So in detail, you may know that acetylcholinesterase enzyme, it has got two sites, one anionic site and one astatic site. So how this hydrolysis of acetylcholine is happening? Yes, so this involves an electrostatic attraction of charged N plus ion in the acetylcholine to the anionic site, and there will be a nucleophilic attack to the hydroxyl group of the serine to the astatic site, and adjacent to that there will be a histidine that gets activated, okay, and that leads to the acetylation of the serine. Okay, so acetylation of this enzyme, okay, serine, okay, so this is the hydroxyl and this is the N plus, okay, N plus of the acetylcholine, which gets attached by the electrostatic attraction to the anionic site, and hydroxyl group of the serine, it gets attached to the astatic site, and adjacent to that there will be histidine which get activated, okay, and this acetylated enzyme, it reacts with water to form acetic acid and choline, and this hydrolysis, that reaction with the water, that happens very rapidly, and the astatic site is set free. Astatic site will be set free in a fraction of millisecond. In a fraction of millisecond, it will be set free. Okay, so this carboxylated enzymes, that is reversible inhibitors, they react slowly, whereas the phosphorylated enzyme, it reacts very fast, within very rapidly, within few minutes it gets extremely so as I told you, acetylcholinesterase enzyme, which has got an anionic site, astatic site. So electrostatic attraction to the N plus of the acetylcholine to the anionic site, and the even to the hydroxyl group of the serine, there will be nucleophilic attack. So that's how it gets hydrolyzed with a millisecond. So this has been inhibited by the anticholinesterases. Anticholinesterases inhibit this. Okay, that is by inhibiting this, by binding to this sites. So that's how they act. Now coming to the pharmacological actions. So ganglionic stimulation, that is through the muscarinic receptors at high doses, it can cause persistent depolarization, and there will be transmission, blockade of the transmission. Further transmission gets blocked. Then in the cardiovascular system, it can cause bradycardia and hypertension, that is again mediated through the muscarinic receptors. Ganglionic stimulation can lead to increase in heart rate and BP also. So skeletal muscles. In the skeletal muscle, there will be stimulation of the smooth muscles and even the glands of the GI smooth muscles. There will be okay, and the skeletal muscle will be twitching and fasciculations. Higher dose can causes persistent depolarization, blockade of neuromuscular transmission. All this result in weakness and paralysis of the skeletal muscles. And in the central nervous system, there will be improvement in the cognitive function, especially in patients who are having Alzheimer's disease. And higher dose of this may cause excitement, mental confusion, disorientation, tremors, and convulsions. Now coming to the physostigmine, which is a tertiary amine which stimulates the muscarinic and nicotinic receptors, cholinergic receptors, and it even acts so on the NM receptor, that is neuromuscular, in the neuromuscular junction. So what are all the muscarinic actions which has been mediated through the physostigmine? So it can lead to the contraction of the smooth muscles, there will be miosis, okay, constriction of the pupil, BP fall, and even bradycardia. So these are the muscarinic action that has been mediated through the physostigmine. Nicotinic actions are like in the skeletal muscle, since it is mediated through the NM receptors present in the neuromuscular junction. So there will be twitches, fasciculation, skeletal muscle paralysis, and all. What you see here is the physostigma venosum. It's a plant from where this physostigmine is being obtained. So coming to therapeutic uses, it is used in the treatment of glaucoma along with the pilocarpine. So we have discussed about the pilocarpine. Yes. So in glaucoma it is being used along with the pilocarpine, and as an alternative to Mydriatic. Okay. When Mydriatic has been used to test the refraction error, to break the adhesion between the pupil and the lens. Belladonna poisoning. Yes, in belladonna poisoning, to counteract the symptoms of the belladonna, physostigmine has been used intravenously. Bolus repeated at every 5 to 10 minutes, 0.5 to 2 milligram can be given. Okay, and even poisoning with the phenothiazines and antidepressant drugs, also tricyclic antidepressants, such case also physostigmine has been given. About the neostigmine, it's a quaternary compound, so undergoes incomplete absorption, whereas for physostigmine is a tertiary amine, it causes the central blood-brain barrier and has got CNS effect, whereas neostigmine, no effect since it doesn't cause the blood-brain barrier, it less CNS effect, okay, more marked effect on the skeletal muscles, and it has got direct action on the NM receptors in the neuromuscular junction. Coming to the therapeutic uses of neostigmine, it is used in post-operative paralytic ileus and atony of the bladder. Myasthenia gravis, yes, 50 milligram is given orally every 6 hourly, and according to the response of the patient, dose can be adjusted. Next is about the post-operative decardiation, which is caused by the muscle paralysis, skeletal muscle paralysis caused by non-depolarizing blockers. So in order to reverse that muscle paralysis which is caused by non-depolarizing blockers, neostigmine is given 0.5 milligram intravenously, preceded by the atropine. Why? To counteract the muscarinic side effects. Adverse effects of the neostigmine are salivation, flushing, falling BP, nausea, diarrhea, bronchospasm. These are the adverse effects seen with the neostigmine. Other drugs are like tacrolimus, donepezil, rivastigmine, and galantamine. These are the ones preferred in the Alzheimer's disease. In Alzheimer's disease, it's a neurodegenerative disease where there is deficiency of the cholinergic neurons, and where because of the deficiency of the cholinergic neurons, there will be low levels of acetylcholine. Acetylcholine level in the central nervous system will decrease. So, in order to increase that level of acetylcholine, and to so that the progression of Alzheimer's disease can be delayed. So that's the reason the tacrolimus, all these drugs, anticholinesterases, are preferred in Alzheimer's disease. Adverse drug reactions like abdominal cramps, diarrhea, increased secretions, sometimes even twitching, fasciculations, hypotension has been found with these drugs. So these are the therapeutic uses of anticholinesterases in general. So as I told, in glaucoma, physostigmine is given along with the pilocarpine, and even drops of demichirium is also preferred. Postoperative paralytic ileus and atony of the bladder, neostigmine has been preferred. Myasthenia gravis, yes, I have mentioned already about the, according to the response dose being adjusted. An alternate drug what has been preferred is pyridostigmine, since it is long acting. Frequency of administration can be reduced. Okay, that's the reason pyridostigmine is preferred above. If you compare it with the neostigmine, pyridostigmine is the one which has been preferred. Atropine sulfate. Why atropine sulfate? Prior to giving the neostigmine or pyridostigmine, to counteract the muscarinic side effects caused by this neostigmine or pyridostigmine, atropine sulfate has been given. Then post-operative decurarization, that is, as I told, the muscle paralysis has been caused by the to do the overdosage of non-depolarizing blockers. To reverse that, neostigmine is again given, preceded by atropine. Then cobra bite. Yes, in cobra bite, actually, what has been preferred is anti this venom. Anti-venom serum is the one which has been preferred, but to the respiratory paralysis, to counteract that, neostigmine along with atropine has been given. Then in Alzheimer's disease, centrally acting anticholinesterases are preferred. So these are the therapeutic uses of anticholinesterases. Next is about the nicotinic receptor agonist, that is nicotine and varenicline, which has been preferred. So nicotine, it's an agonist on NM and NN receptors. So it acts on both nicotinic receptors. It's a short replacement therapy in abstinent subjects, and the small and short lasting effect on the baby and heart rate. So those who want to get relief from the habit of smoking and tobacco chewing, this nicotine or varenicline is the one. Varenicline is the one which has been preferred. So adverse effects are, which is seen at the toxic dose is fatal dose is 40 milligram. The toxic effects are like salivation, vertigo, excitation, mental confusion, arrhythmia, cardiac arrhythmia, muscle twitchings, convulsions, and all are the toxic effects seen because of the nicotine. Now about the treatment. How do you treat the patient who really want to quit smoking or tobacco chewing? So what is the goals of the nicotine replacement therapy? Is you have to reduce the craving effect of the nicotine and to suppress the withdrawal symptoms. For this, the drugs used are the nicotine replacement therapy in the form of transdermal patches or even in the form of chewing gums. It is available. Then another drug what is being preferred, it's a partial agonist of the nicotinic receptor, that is varenicline, and then the bupropion, which is a typical antidepressant. So you can see here nicotine transdermal patches that can be applied over the thighs, over the chest, lower arm, and all. It has been used. So it can really help the patient who wants to quit smoking, and it can even say a substitution. It can reduce the withdrawal symptoms, but the craving, up to some extent you can reduce it, but still that craving will be there among the patients. So that that variation in the blood level during that can be managed with the nicotine. So that's about the transdermal patches, nicotine transdermal patches. Another what has been recommended for the replacement therapy is the chewing gums, nicotine chewing gums. So this nicotine chewing gums, comparing to the transdermal patches, this has found to decrease the craving also up to some extent, even the withdrawal symptoms, but it has found to cause some adverse effects like abdominal cramps, diarrhea. Okay, and it is contraindicated if the patient has any history of stroke, arrhythmia, pregnancy. All these are like contraindication for this nicotine chewing gum. Okay, so that's about the nicotine. Next is about the varenicline. Varenicline is a partial agonist of nicotine, which is available as tablets. So what it does is they release dopamine in the nucleus accumbens, and which imparts a feeling of substitution or reward in the patients. So some level of nicotine substitution is being done by the varenicline. That is because, but being a partial agonist, that craving will be there, and it has found to cause mood changes, irrational behavior, appetite, then taste disturbances, sleep disorder, agitation among the patients. So these are all the adverse effects seen with the varenicline. But one more thing, what has been warning, as a warning, it has been given about the usage of this varenicline is about the suicidal tendency. That has been kept as a warning signal against the use of varenicline. So these are the references for the further reading. Thank you everyone. Happy learning.